practice?
Well, yeah, I think if somebody comes in for refractive surgery and they have topography done and there's some other clinical signs that point towards keratoconus, they're not going to have refractive surgery. But also that patient may be 20/20, and that's one of the reasons they don't necessarily know, or their local optometrist or fitter didn't know that they had keratoconus. I mean, at that point in time too, especially where we're at, it depends whether or not they have cross-link. It depends on a lot of factors, their age, if can we prove that they're progressing, what's their acuity and that type of thing. So I don't think there's one obvious checklist for that group of patients. It depends on a lot of factors, and sometimes we may have them back and repeat topography and that type of thing, and have that initial discussion. But it just depends on the patient.
So what I do, we call it the talk. Okay. Now my corneal surgeons that I work with, they will not see a cone unless that person has seen me first. Okay, that's the way we have it set up. You can't get to this. You cannot get to the cornea team unless they go through me. Okay, and we've had this whole thing. It works out really well. I do the talk, and what it is I pull up their topographies. I go over. I talk to them about what keratoconus is, what it means, and then make sure the patient understands that I know how it affects their world, and I know that their life wraps around this disease. I show them their topographies. I explain it. I point out. I have a big monitor. Everything's pointed out there. I go through what we know about the genetics today. I go through what we know about the pros and cons specific to them for the treatment options that we have, and I go through their contact lens options as well. And I make sure, and that's the talk. It takes about a half an hour in my practice. You don't have to solve all of their problems in one day, so we do the talk. I give them resources, information, places to go. I let them know that there are social media groups that they can talk about it with. I also let them know that there are very unhappy people in those social media groups, and that they should not wrap their mental health around talking to other people. Well, and that if they have questions, they should come and about treatment options. They should come and talk to me about it, so I'll put it in terms of them. And then I bring them back to fit.
And certainly a comprehensive approach is good, but the other thing too is, especially a lot of those patients, let's say it's a 35-year-old patient that comes in, they have keratoconus, they didn't know. I mean, there's a reasonable chance that nothing will ever happen to them, that they'll be always fine. So you don't want to scare them as well. You certainly want to give them enough information. Even the genetic information, as we know now, is important. But you don't want to scare them, because at that stage, there's actually a great chance, depending on, again, on their age, that they'll actually always be fine.
And I let them know that if I think they're going to be fine, absolutely. I say, you're going to talk to people in these groups that have horrible, horrible things, had transplants. That will never be you if you listen to what we're saying.
Let me just add one comment to that. And on the pellucid, I kind of agree that I didn't think it was all that difficult. I think between topography and tachometry, you could isolate them. And I totally agree that we'd always get a lot of people referred that they thought weren't. But here's, as part of your talk, and that sounds like a wonderful approach, as part of your talk, what do you tell them when it comes down to surgery? Because we've traditionally felt it's 1 in 7. It hasn't been usually 10 to 15% will end up with a PK, or today, some form of surgery. But now you have sclerals, now you have cross-linking. When we're having the talk, what do we tell them about the...
Well, okay, my personal practice, I feel like I'm on the all keratoconus all the time channel, right? So I see so much of it that I feel like I just use my spidey senses of whether I think they need surgery, right? But if you have somebody comes in, their pachymetry is still 450 and they're good and you can refract them well, I'll tell them, you quit rubbing your eyes, you quit doing these things in life, if cross-linking's on the table, do that. Whatever we feel is medically appropriate for them. And I'll say, the chances are you're never going to need surgery. I don't give them a statistic because I feel like it's so individual for that particular person. Because I have to wrap the rest of their life around. I have some individuals, they have behaviors, right? Compulsive behaviors. They're much more likely to need surgery or cross-linking or something along those lines than people that are not compulsive about their behavior. So I don't know, what do you tell them?
Yeah, it's the same thing. It's just educating the patient, and it's patient specific, because there's so many variables in the soup. You can't cover everything per se, but you want to be specific and look at each patient and see where they're at in that spectrum.
And I tell them, stay engaged with me, and we will keep up on all of this, and I'm there for you. We're there for you.